So good afternoon and welcome to Bridges at Lakeview Health, our educational series that connects addiction and recovery subjects to our communities across the nation. We want to thank you all for joining us for this special event. Today, we will be presenting on the history of racial bias in medicine, the racial disparities relevant to COVID-19 and substance use treatment, and the laws that have impacted the lives of Black Americans in academia and in practice settings. For those unfamiliar with Lakeview Health, we are an adult-only addiction treatment facility located in Jacksonville, Florida. Since 2001, we have been leading the way in how addiction is perceived and treated and how recovery is managed. We are a passionate team of difference makers whose mission is to empower profound recovery through exceptional, dynamic, and evidence-based care for all individuals and their families. Our commitment to our patients does not end at discharge, but is for a lifetime. Before I hand it over to Dr. Dornby, who will be introducing our presenter today, I wanted to share a few housekeeping items. Throughout the entirety of this presentation, participants will have the ability to submit questions via the Q&A section to the right of your screen. At the end of the presentation, you will be allowed a few minutes for any additional questions to be added. All questions will then be answered by the presenter. The chat box is for conversations between participants. You are all muted throughout this presentation and communicate with each other via the chat. Please do not ask any questions for the presenter via this chat box. As a reminder, in order to receive the certificate for continuing education credits, you must be in attendance for the entirety of the presentation, complete the event evaluation, and pass the post-test with at least a 70%. We will email participants the evaluation and survey information along with the event recording within 24 hours following this event. If for any questions you may have, please email me at events@lakeviewhealth.com. Thank you, and now to Dr. Dornby.
Thank you so much, Allie. We at Lakeview Health are very excited to be hosting Dr. Jean-Luc Cadet. Dr. Cadet is a well-respected professional at the National Institute for Health in Maryland. His research over 20 years, and in particular, numerous trainings and committees and studies on racial bias in academia and the medical profession, make him a leading expert on this topic. Dr. Cadet is a senior investigator and tenured at NIH. He's the chief of Molecular Neuropsychiatry Research Branch and the chief of the Molecular Neuropsychiatry Section. He is also the NIH NIDA Intramural Research Program Director. Dr. Cadet attended Columbia University College of Physicians and Surgeons, from which he obtained his MD or medical degree in 1979. He completed his residency training in psychiatry at the Department of Psychiatry at Columbia, and he completed residency training in neurology at the Department of Neurology at Mount Sinai Medical Center, both in New York City. He went to the National Institute for Drug Abuse, IRP, in 1992, where he is presently a senior NIH investigator and the chief of the Molecular Neuropsychiatry Research Branch. Dr. Cadet has co-authored more than 300 papers, abstracts, and book chapters on the mechanisms of addiction and brain damage. Based on the citations of his papers, his H-index is 87. He has written papers about cognitive dysfunctions observed in cocaine and marijuana users, and presently his lab is studying how stimulants and oxycodone can cause epigenetic, transcriptional, and biochemical changes in the brain. For more than 20 years, Dr. Cadet has been the committee co-chair for the Minority Research Training Program at NIH NIDA, the chair of the Diversity and Outreach Committee, and a member of the National Institute for Drug Abuse Study group on health disparities. He has also been a standing NIDA committee member for minorities, women, and other underrepresented populations. We are so delighted to host Dr. Cadet, and without any further delay, Dr. Cadet, the floor is yours.
Thank you very much. I wish to thank the organizers of this afternoon presentation. I'm trying to share my slide now, and hopefully you'll see it. Are you seeing my slides? My
Yes.
slides coming through?
They're covered up by some of the other parts of the computer. There they are.
Okay.
They're up now.
There you go, Dr. Cadet. You have everything all in place now.
Okay. So, so this afternoon, what I'm going to do is talk to you about the racial inequities that have been reported for a long period of time in medicine, science, and substance use disorder diagnosis and treatment. And I'll be also talking about the disparities that have been reported in COVID-19. So, as you all know, there are important racial disparities in health. And several investigators are publishing several excellent journals about hypertension, diabetes, chronic kidney disease, strokes. But the ones that are really very troublesome, are the high maternal and infant mortality rates that have been reported, to the extent that in some areas of the country, both maternal and infant mortalities are comparable to some of the poorest countries in the world. And since this is related to substance use disorders, we'll be also talking about the diagnosis and treatment of SUDs and the racial disparities associated with those. So this is the outline of my talk. I'll be talking about the political and economic forces driving these racial inequities. I'll talk about racial inequities in medicine, including experiments that have been performed without informed consent. We'll talk about disparities in inequities in medical staffing and NIH grant reviews and awards, racial inequities in the clinical course of COVID, and we'll end with a discussion of substance use disorders. Now, before we go further, I'd like to provide you with some definitions, because there are often some confusions about what these words mean. Health equity. When you talk about health equity, we're referring to the opportunity for everyone to attain their best health potential. Okay, that's health equity. Health inequities refer to differences in health that are secondary to economic, environmental, and/or social disadvantages. And health disparities are differences in health and disease outcome between ethnic and racial groups. Now, this picture actually is one that I copied from a publication. It's really worth mentioning here because equality is not equivalent to equity. So in the case of equality, you can see everybody standing on the same box, but the person, the individual in yellow, is not really able to see the game. But when we talk about equity, there might need to be additional boxes added here so that the individual in yellow can see the game as well as the individual in blue. So we have to keep that in mind. And when we discuss, okay, what can be done, for example, to improve treatment of patients who suffer from substance use disorders. So one of the quote that I really like a lot is below. For example, when people are used to preferential treatment, any discussion of equal treatment is seen as divisive or inflammatory. Okay, so one of the things that happens when we start this kind of discussions is that the people in power try to silence people who dissent. Okay, so what happened to dissenters? You know the story of Dr. Martin Luther King and the story of Malcolm X, right? These people, really brilliant Americans, were silenced in their primes. Luckily, we have people like Representative John Lewis and Supreme Court Judge Thurgood Marshall, who actually got a chance to live to continue the fight in various arenas. The other thing I think that it's very important to keep in mind is that there are various dimensions of racism. In this slide, we talk about 4 of them. We talk about institutional racism, okay, structural racism, interpersonal racism, and internalized racism, okay? So these are issues that you should keep in mind. So there are a lot of different levels, and structural racism can really impact everything that happens, whether institutionally, interpersonally, or in individuals. But let's talk now about the political and economic forces that have been driving racial inequities in our country. So we need to go back to 1619 when the first enslaved Africans were brought to the shore of our country, and that lasted, slavery basically lasted from 1619 to 1865 at the end of the war. But this didn't stop poor treatment of African Americans. As you all know, segregation continued until the Supreme Court decision of 1954. But even after that decision was made, we still have segregated housing, segregated schools, segregated institutions that really block what the country could have reached. So I don't know if you're aware of some of the laws and related to housing. So people talk a lot about mortgage redlining. So there was this organization called the Homeowners Loan Corporation. So they basically prevented middle class or upper middle class Black Americans to move into certain neighborhoods. So that if you apply for a loan and if you wanted to move into a better neighborhood where they're mostly majority white Americans, they would not provide you the loan. So we ended up with what's called mortgage redlining and housing redlining, so that Black Americans were concentrated in certain neighborhoods all around the country. So the GI Bill is one that people don't know a lot about. Is when the Second World War ended, and all of the Americans who fought in the war came back, the GI Bill really helped white soldiers move into the middle class, upper middle class, but the Black American veterans didn't have access to the GI Bill for educational purposes or to start business. So those are the type of things that we're not taught in school, but we should be aware of this. When we talk further along the talk, you have to keep in mind that health, okay, the health of our patients is determined by very important social determinants, right? So here, this slide shows the socioeconomic factors. 40% of health of our patients are determined by socioeconomic factors, okay? Physical environment is only 10%. Now, health and behavior is very important, 30%, and a lot of people don't have access to insurances. So you can see that 40% and 20%, that's a large number, even though, as you know, if you don't eat properly, use too much alcohol or drugs, you can really impact your physical and mental health. Now, this book is a very, very important book to own and read because it really goes into some of the aspects of the various laws that were passed in this country. So the government itself was involved in creating a system that Black participation of Black Americans in the health and the wealth of this nation. So let's talk now about racial inequities in medicine. So this, what I've noticed during the time I've been in medicine, and also from my reading of the old literature, is that often white physicians behave more like racist supremacists, which is what I never expected that as a young medical student at Columbia University. And there are stories about Columbia University I could tell you, but we won't go into that for this presentation. But they also, in the case of my own universities, behave like white colonialists, great white saviors, basically engaging patients without necessarily telling them what they were doing and what research they were participating in without back in those days without consent. There's this data, those are data, those are not opinions. These facts have been documented in terms of what that previous slide, in books like Medical Apartheid by Harriet Washington, The Political Determinants of Health by Daniel Dawes, Killing the Black Bodies by Dorothy Roberts, and Medical Bondage by Deidre Cooper Owens. And they talk a lot about some of they narrate all of these occurrences within medicine. This is very, very sad for me, for example. Now, in terms of the cultural proficiency in clinical research, now a lot of times people complain that Black Americans do not want to participate in clinical research. This is actually due to knowing what has happened in the past. So I'm sure most of you are aware of the sterilization of Black women. A lot of this happened in the Carolinas. The experimentation on enslaved Black women. And you've heard about the story of Henrietta Lacks, okay? So this is an example of a physician, an OBGYN physician, Marion Sims, who is really very well regarded in the medical community. But what Dr. Sims did was experimented on Black enslaved women and without the consent. If you are an enslaved person, you cannot give medical consent. So Dr. Sims would practice surgery on Black enslaved women in order to correct vesicovaginal fistula. Once he perfected his skills on these enslaved Black women, then only then will he use his skills to correct the fistula in white women. So this is very distressing when I find out about this. The story of Henrietta Lacks is very close in terms of where I live and work. I work on the ground of John Hopkins Bayview, even though I'm a NIH investigator. So what happened with Henrietta Lacks, she was a mother of 5 children, and she presented to Hopkins Hospital with vaginal bleeding. At the time, Dr. Howard Jones, discovered a large cervical tumor, which was removed and treated with radium therapy. But the Dr. George Gay, a virologist and cancer researcher, took a cell and developed this immortalized cell without ever taking Mrs. Lacks that her cells were being used. So that what ended up happening is that he published a number of papers in the 50s using this cell. And Hopkins University made a fortune selling these cells. And those cells are used still today to develop a number of treatment and testing therapeutics. Only recently, as Hopkins recognized this error, and now they, whenever intern and residents come to Hopkins, they actually are really open about telling their history of racial discrimination in Baltimore. And I think it's important that all of us follow what Hopkins is doing, because this is very, in order for us to have a reckoning and basically start working well together, we need to be discussing what it is that we did wrong. You've also heard about the Tuskegee experiment. That experiment lasted 40 years. During that time, a number of Black men who were infected with syphilis were not treated, even though it was proper treatment were being provided to white men who were infected with the syphilis. Now you would say, wow, there are a lot of Black men who were infected, but this didn't really just impact them. It impacted their whole family, because these men would have intercourse with their wives. Some of them would get pregnant, and their babies would be born infected in some cases. So this is a terrible thing that happened, and the U.S. government was directly involved in this experiment. So those are the type of things that when people say they don't trust the U.S. government, you have to go back and say, wow, no, there's a history there that it's not that people are necessarily paranoid. Now, I should say that during those years, as you're well know, the American Medical Association refused to give membership to Black physicians. The Black physicians created in 1895 their own National Negro Medical Association. Now it's called the National Medical Association, and I'm a member of this association. Now, what about medical staffing? You could say, wow, this is happening to patients, it's happening to people, but once you become a doctor, it's all fine and good. But that's not really what happens. So this is really important that we have enough Black physicians in enough specialties to take care of patients, both white and Black patients. This is because teams that have members of different groups think about problems differently and usually come up with creative ways of dealing with scientific questions. This is well documented in the literature. You can go in the internet, look for this on Google Scholar or PubMed, and you'll see documentation of these facts. Diversity helps to balance and broaden perspective in terms of setting research priorities. In this case, I would say treatment priorities. And the presence of scientists and physicians from different groups and backgrounds increase the likelihood that issues that affect underserved populations are discussed. This is, a lot of times I'm in discussion group and then people are talking and they are somewhat oblivious of issues that are related to Hispanic Americans, Native Americans, African Americans. And I say, what about this group? But if I were not there, then those issues would not be discussed. So you think that the NIH, based on what I just said, is science is it's well documented in the literature. There are a lot of scientists at the NIH that follow the objective data, but that's not actually what happens, even in an institution like the NIH. So this slide was made by one of the tenured senior investigators at the NIH, and he documented the number of African American scientists, and I'm going to focus on the senior investigators, those with tenure. For example, in 1994, 2 years after I arrived at the NIH, there were only 8 tenured investigators of African American backgrounds at the NIH. Now look, 10 years later, there were only 10, okay? And then, so that tells you, this is a really very low percentage. When you compare the number of total scientists at the NIH. So look at the numbers, 835 for white Americans, 10. That's really about 1% of tenured scientists at the NIH of African American background. This is not very, very good for the NIH. So now, last year, in 2020, so we went from 2004 with about 10 to 2020 with 13. That's only 3 people in a span of 16 years. So the percentage is down here. So we make up, Black Americans only make up 1.2% of the senior investigators at the NIH. And you see some other groups like Native Americans that are not very well represented either. Now, so the underrepresentation is also seen in U.S. faculties at medical school. So as you can see here, white Americans are very well represented as physicians. Asian Americans are also well represented, but Native Americans are very poorly represented, and Black or African Americans are only 2.7%. You should remember that Black Americans make up about 13% of the population. Hispanic Americans are a higher number, about 3%. So there are groups that are not represented, and we can say, and I dare say, that this is due to institutional racism, where medical schools are just not accepting enough Black American and Latino Americans into their medical school. Now, so in medical school, the numbers are really low. So what happens then when you start looking at physicians who are practicing medicine? Again, white Americans are very well represented, so are Asian Americans, but Black Americans by about 6%. Again, that's a very low number. So there are places then that are going to be mostly African American population that don't have access to physicians. And obviously, if they don't have access to physician, there's going to be poor care. Now, this is not only related to numbers of African American scientists and African American physicians. When some investigators had looked at numbers of grants. So after people go through medical school, they get the degree, they do fellowship like I did, they go into science. Okay, so they're working at medical school and they're trying to get grants to pursue their dreams. Then, even then, when their grants are reviewed, they don't get this grant at the same rate that their white counterpart get grant. So here, this paper was published in 2011, and so what those authors concluded was that NIH training, experience, getting previous grants, the number of publications, or their citation rates did not translate into the same probability of grant success for African American applicants as white applicants. So this is somewhat distressing. As Americans, we should all be very upset about these numbers. And right now, the director of the NIH, Dr. Francis Collins, is trying hard to see if we can change these numbers. But whether this happens or not will remain to be seen. Another paper published in 2019 was a follow-up to the 2011 paper. So over 8 years, okay, those facts that I just related to you did not change. So you can see here, there were a lot of grants that were reviewed. Almost 160,000 grants were reviewed. And what they found was the funding rate for white, okay, in both 2011 and for 2019 were much higher than for African American scientists, which came in at 16.1% and 10% scientists. One thing you should notice is that the numbers went down mostly because the funding rate and the amount of money available for funding went down during those years. So we need to push the government to provide more money to the NIH. So because of frustration, Black scientists were much less likely to resubmit their grant application than white scientists. One of the things that the authors concluded in their 2019 papers was that awards based on animal and human studies, or both, African American scientists tended to submit more human studies than white scientists. Grant from African Americans went to Division of AIDS, Behavioral and Population Science. Grants from African American scientists fell into 8 clusters, and 6 of the 8 clusters had award rates way below NIH average. I mean, this is what I call very unfair. And topics focusing on disease prevention, which is very important to the whole country, and intervention, also important for the whole country, were less likely to be funded by the NIH. So we need a revolution at the NIH so that studies that focus on prevention and intervention can be better funded. I mentioned this to you before, so what I've done is showed you how structural racism, the government, all of multiple institutions, doing the same racist thing. And at the institutional level, I've showed you that the NIH is a culprit. And now, for the interpersonal, is that the people who are reviewing grants, they're making bad decisions and not giving grants to African American scientists. Now, so what I wanted you to think about during the talk is how do we go about fixing these gaps? Okay, do you have some ideas that you can write me email, write the NIH email about how you think that should be addressed? How do you change the minds of reviewers? Find low priorities to studies that focus on prevention and racial disparities in health. Again, this is really very important for the country. Will implicit bias training. For example, I have to go through implicit bias training every year. Will that be enough to remedy some of the problems associated with grant reviews and the provision of medical care? Our AIDS really, the COVID last year pandemic really brought us to actually having to analyze more deeply the racial inequity and disparities that exist since the post-civil rights era. Okay, so there is nobody, I hope, who's going to say that these inequities and disparities don't exist. With COVID, we've seen unequal health care. That unequal health care is still present. We discussed all of the targeted sterilization of Black people. So a lot of people were writing papers about this. There were several papers on Black maternal death rates and infant mortality rates. One of the problems with the infant mortality that was really terrible was the fact that infants who were taken care of by Black physicians, Black neonatologists, fare much better. So you would think that once somebody had access to any physician, that an infant would do well, but that wasn't what was the case. This paper was published in a major journal called PNAS, Proceeding of National Academy of Sciences, last year. I was dumbfounded when I read these papers. And now in the next few slides, let's talk about COVID-19. So what we talked about before, we have these disparities. And one of the things that people started to observe was that patients, Black patients, and also white patients who have this hypertension, diabetes, other infectious diseases were more likely to suffer from COVID, a bad course of COVID disease. Now, this slide showed COVID diagnosis, okay, and COVID death. What you will notice is that the highest prevalence of COVID-19 was found in areas of our country that were disproportionately Black, okay? And again, when you look at the death rate, the same thing is evident, okay? So what I'm going to do now is discuss some papers that came out of some of these counties around the country. Now, so the first one I want to talk to you about is a paper from Newark, New Jersey, okay? So what they found was, again, that Black patients were more likely to suffer from mortality and hospitalization than white patients. And they found that hypertension, as I mentioned before, problem with cardiac problems, chronic kidney disease were more likely to suffer death in New Jersey. Now, you could say, wow, this is only New Jersey. Now, here's a paper from Detroit. Again, they came to the same conclusion. Being of African American ethnicity made it more likely that you might be impacted in terms of dying. And this is a paper from Louisiana. This paper was better written than the other ones. They look into a large population. They had really large numbers of patients, and they were able to document whether people had health insurance or not, coexisting conditions like diabetes, obesity, hypertension, and they basically reached the same conclusion. And this is a summary from that paper. African American patients had increased prevalence of obesity, diabetes, hypertension, and chronic kidney disease. 77% of patients needed hospitalization for COVID-19 were African Americans, and 80% of those required mechanical ventilation. Now, all of these diseases are related to racism and poor medical care. So COVID really opened the wounds that Black Americans have been suffering from by pointing to them yet again, that a disease like an infection also, they were more likely to die from this infection. Now, contributory factors and COVID inequities, the testing criteria, existing medical problem, provider biases, that's really a big problem. Medical apartheid. There were reports that some hospitals were not admitting even some Black patients who were suffering. Black Americans were more likely to be exposed on the job. They were more likely to take public transportation together with other people who might or might not be infected. And structural racism, right? We talk about that. Structural racism ignores the plight of those at the bottom of the wells. A lot of African American and Hispanic American find themselves in those positions. Now, we cannot talk about COVID and not talk about vaccine distribution. So one of the myths that has been created by a number of individuals is that Black Americans suffer from vaccine hesitancy. That's why they're not getting the vaccines. They're afraid of being exploited. That's true, but that's not the main reason that many people have found why Black Americans are not vaccinated at the same way. In the case of vaccine hesitancy, what was reported a few weeks ago is that 40% of white male who identify as Republican said that they're not going to take the vaccine. But the focus, though, was mostly on Black vaccine hesitancy. So what I think we need is distribution of vaccine in places where Black folks live. They should take buses to those places so that people can have access to vaccine. The other problem also, this happened to me when I was trying, because I'm not in primary care, I needed to actually get myself on the schedule of the hospital around here. Now, even though I have complete access to everything, it took me a long time to finally get on the schedule. And I had to put myself on a lot of different lists and in order to get the vaccine. So there's a lack of access because of lack of adequate transportation in cities like Baltimore that are very segregated. And finally, let's talk about substance use disorder. Now, what are the racial inequities in substance use? Among Black Americans, young adulthood marks a period for the initiation of drug use. Okay, discrimination has been shown to influence the prevalence of problematic drug use and the development of diagnosis of substance use disorder. Okay, just drug use enough is not equivalent to a diagnosis. So you have to meet this criteria in the DSM and go through to a doctor or nurse or practitioner or social worker who can make the diagnosis. So we shouldn't think that everybody who uses drugs meets the criteria. I think it's important for all of us as professionals to make sure that parents and patients and government agencies know about this. Black pregnant women are less likely to receive treatment against opiate use disorder than white women, pregnant women. Okay. Despite lower rates of opiate use disorders, overdosage, the prevalence of overdosage among Black Americans are now outpacing those among white individuals. And there are papers about that, and nobody seems to be paying attention, even though many of us professionals are aware of it. Now, how do we get to there in terms of substance use disorder? Okay? Racism plays an important part. The stress of living in certain environment, smoking. Black Americans are still smoking at too much. And, I try to convince some of them to stop smoking. It's not, it's difficult because companies advertise in low-income communities a lot. Poverty, okay, lack of adequate housing, depression, or the psychiatric diseases then you have comorbidity, and which is an important issue that we can talk about a little bit later. It's really important that places that treat patients with SOD can also treat other psychiatric diseases that those patients can present with. I think one of the worst things that happened in the United States from starting in the 1970s was the criminalizing of young people from Black communities. Okay, so at the time of the passage of the 1990s crime bill, okay, most white scientists knew that crack cocaine and cocaine were the same drugs. I knew that. A lot of people knew that. But one of the things that happens is that professionals like me behave like cowards and never presented in a very really aggressive way, for lack of a better word, to our government agency and our government officials and tell them that crack cocaine and cocaine are basically the same drug. So they shouldn't be sending young Black men and women to prison for such a long time. They should have spent the money to open more treatment programs so that people don't have to rot in jail. I mean, when somebody's in jail, they're just not getting treatment. So this is really, this discussion is related to what it's called the Penrose effect. This slide is out of a nice paper by Greco and Chambers that was published in 2019 in Translational Psychiatry. I think it's worthwhile for everybody to read that paper. What Penrose did, Penrose is a British psychiatrist who was really interested in a lot of social issues. What he found was that in countries that don't have proper treatment infrastructures, what ended up happening was that a lot of our patients ended up in the penal system. Okay, so you can apply the Penrose effect to what the war on drugs. Okay, so the war on drugs, it's not just start. It didn't start in 1990s. Started under President Nixon in the 1970s. He uses racism to basically win, in order to win the moral majority. He started to put young black people in jail. Then came the Crime Bill of 1994. These policies basically made into a crime compulsive drug use, okay, which should be a medical psychiatric problem, okay? Since the 1970s, the U.S. has spent more than $1 trillion annually to pursue and incarcerate mostly low-level drug users who just happen to be black and brown individuals. This is very racist, okay? So these people should have been, the money should have been better spent to send people to treatment programs. The U.S. actually spends more money on arresting and jailing people who meet the diagnostic criteria, okay, for substance use disorder than in diagnosing and treating them. Michelle Alexander's book, The New Jim Crow, is an outstanding thesis discussing some of the impact of the war on drugs on the African American communities in various cities. Now, the Penrose effect, I can, instead of the calling it just the Penrose effect, that you can say the war on drug effect. So here, no, there's a lack of addiction treatment infrastructure, and then you impose the war on drug on that. So the number of individuals that have been incarcerated is just unbelievable. It's too difficult to talk about that now. It would take a whole day or several days to discuss the impact of war on drugs. Since we don't have that time, please buy that book that I referred to, the Michelle Alexander book. So those authors also talk about harm amplification. So you put people in prison, the numbers go up, and then you end up with even more people with psychiatric disorders because they don't have access to treatment. So we really need to be proactive in terms of trying to defend our patients against racism that send them to prison. So actually, so I'm going to go forward in order to talk about research. There's also a need for more research in the African American as far as addiction research is concerned. So I have to admit that there's some resistance from certain communities, but also there are personal biases from scientists that really may not want to have African American patients in their studies. What I'd like to say is that researchers use basketball paradigm where they think that, okay, if they have two great players, they're going to win the match, but that's not really good to apply for to SUD. We should apply a soccer paradigm where we think of everybody in the group has to be the best possible player that you hire at your hospital, in your research setting, in order to take care of patients who suffer from SUD. Because SUD is a very complicated disease of the brain. So So we need to know who are the messengers when we approach the African American population to involve them in our research program and our treatment program. We also need to know who are in the audiences that we're approaching. I think it's very important that treatment programs hire Black physicians, Black nurses, Black social workers, if they're working in communities where there's a high number of African American patients with psychiatric and other psychiatric disorders and substance use disorders. And by doing that, by interacting with these communities more closely, we hope that we'll be able to get over some of the mistrust of white institutions on physicians and researchers. The other thing that people should keep in mind who are treating Black patients, they should keep in mind the fact that they are economic constraint, so that if they miss an appointment on a given day at a given time, it's not because they're resisting treatment necessarily. It could just be that there are some constraints that are blocking them. So we need to do outreach to make sure that we can be helpful in helping patients get to where we need them to be in order that they can be provided with the right kind of treatment. So I'm getting towards the end. So what I want you to do is some self-examination and think about how you felt when I was talking about the facts about the racist history of science and medicine, including the war on drugs. Were you surprised about some of these facts? Did you know them already? What changed, especially that you would like to see happen in practice with regard to substance use disorders? I mean, that's what we are here for. How did you feel when George Floyd was murdered, and then we all watched it? I don't know too many people where I am who didn't watch the tape. But why did it take that murder for all of us to finally say, enough is enough? Let's try to work together in a positive way to impact the lives of everyone, not just white Americans, but Black professors, Black patients with substance use disorder, and increase funding related to those issues. How can you fight racial injustices? You can name racism when you see it and hear it. Don't just talk about it. Don't just virtue signaling. Get some plans that you can put into action. Okay, help to raise funds for Black causes, Black HBCUs, and have to facilitate workshop. For example, you can see that I was invited to give this talk at Lakeview. They are very, this is very important to them. So these are the type of things that we expect other professionals to do. Invite those of us who really think these issues are important. Challenge those individuals who claim that the lack of diversity and inclusion in science and medicine is due to problems with pipeline. The pipeline issue is a myth. This is not what the issue is. There are enough Black students graduating colleges with science degrees for them to be admitted to medical school. So an important point to remember, it's racism that I'm fighting, okay? I'm not fighting the non-scientific classification of race by Linnaeus. I mean, he made this classification based on nothing. There was no scientific basis for it. It's racism. It's racism that causes disparity in science, medicine, and SUD research and treatment. So it's not the fact that it's not the existence of white people. I think it's great to have a lot of different people in the world, but racism is lacking us for all of us actually to meet our potential. As a country, in order to get to that level as a perfect union, all of us have to fight racism. So my final comments, Black physician matter. So if you know a young Black man or woman, try to get them to go to medical school. Black scientists matter. If you know Black scientists, support them. So I think, and some people disagree with me, that we need new medical schools that are affiliated with HBCU, historically Black colleges and universities, because the medical school that exists right now are just not enough to train the number of Black physicians that we need in the country. I believe sincerely, because I came to the United States from Haiti, I believe that the U.S. is the best hope that we have to do better on these issues. Racism is not just an American issue, it's a British issue, it's a French issue, but we need to lead the way, because we can do better so that these other countries can follow in our footsteps. And those interested in doing better should read books like the book Sent from the Beginning by Ibram X. Kendi, okay, is at Boston University. There's a more recent book by Teresa Robinson, where she talks about what, mostly Black women have to go through. And then this book is somewhat of an older book. It's countering the conspiracy to destroy Black boys. So if you destroy Black boys, they cannot go to college. They cannot become physicians. So we need to make a big effort. And some of my friends, especially Winston Powell, who's at the University of Connecticut, she's working really hard with Black boys and men to improve their mental health. So we need more people involved in those activities. So what I've done for you today is present some data that show that there are structures, okay, that impact the lives and the health of Americans, specifically Black Americans. Poverty, inequality, housing where people live, the type of jobs that they have, health can influence outcome. And I talk a lot about maternal mortality, infant mortality, and all of the diseases such as hypertension, diabetes, chronic kidney problems, and obviously COVID-19. And so we also should think about the vaccine. How do we get the vaccine to where the people are? To end, I would like to suggest that we try our best not to harm each other. I mean, this is the first do no harm is something that I learned as a first-year medical student. I was very, very hurt when I actually noticed some of the harm that physicians could do to patients. But the United States was founded with the idea of liberty, justice, and the pursuit of happiness by all. So we need to make sure that we can set up structures and that help all of us realize these three things. And I think we need to be insightful and think about our own behavior towards each other and try to document within our own mind behaviors that we now know could be racist and pay attention to that when we're interacting with our patients. So with that, I'd like to thank you for listening. And I thank the Bridges at Lakeview for inviting me to participate in what I think is a very important community program. Thank you very much. Hello?
Thank you, Dr. Cadet. That was a wonderful presentation. We are really grateful to have you present on this very important topic. I think we have some questions that Allie will be asking. Okay, I'm not certain if Allie's still on, so let me jump in.
Okay.
All right, so we have a question from one person. Research in the opiate epidemic seemed to indicate that there were fewer overdose deaths among African Americans because doctors did not treat pain in African Americans equitably.
So at the beginning, that was what people were thinking, that the overdose death was mostly in some areas like rural areas, mostly white Americans. But there's actually now two papers that have come out and documented that even though the prevalence of opioid use disorder is higher in white Americans, which is true, the prevalence. Okay, so it's not just the numbers. So you have to look at the numbers and look at the number of African Americans in comparison to white Americans who suffer from the same disorder. So the percentages, when you look at the percentages right now, it's looking like more Black Americans are actually overdosing. Not the total number. The total number is still higher for white Americans.
And, you know, I think I also saw an article that came out in the New York Times about suicide rates in African Americans and minorities actually spiked in the middle of the pandemic. And
That
I think that,
yeah, I got the same New York Times article. And then actually, one of my friends sent me an email with the figure on it. It's actually pretty troublesome during COVID.
yes, and I think we'll only continue to see that number probably climb as we get out of COVID. Here's another question. Someone asks, what role do you believe immigration policies play in improving and strengthening our neighborhoods and communities that deserve and need our attention?
That's a tough question. So I mean, from my perspective, obviously I'm an immigrant, and I think it's very important to open the frontier to other people who are seeking freedom and liberty and happiness. We have enough places for people to move into. There's some areas of the country where if people would move there, we could really make this a much better country. So the health care in the country is not being impacted in the way that people are saying because immigrants come in. So before all these immigrants were coming in, people didn't have access to health care. They didn't have medical insurance to go to the physician. There were still shortages of Hispanic and African American physicians to take care of patients. So I think there's a minimum impact on the health of our country. The one problem, though, is that there were some physicians who were coming from some countries like Pakistan and other countries to do their training here and stayed and practiced in some areas where there were shortages of physicians. With some of the policies of the last 4 years kind of blocked the arrival of those physicians onto our shores. From that perspective, I would say, oh, wow. But I think the most important way to increase the number of our physicians is to increase the number of medical schools where we can train Black physicians.
And I really like that idea you have of connecting or affiliating HBCUs with medical schools, because I think that's a really very intriguing idea. Another question we have, kind of along that same line, is what are the statistics of how many people of color apply to medical school?
Okay, I don't know all of the exact numbers, but what it ends up happening is that a lot of people apply to the majority medical school and get rejected. Okay, I've talked enough with a lot of young black kids who, when I look at their records, say, "Wow, you should have been able to get into medical school." But what the white medical schools do is they have a tendency to accept the same black men and women to their medical school. Okay, so there you see young black, I guess by that time they're adult, like 22-year-old, 23-year-old, who get 6, 7, acceptances. And and then what I try to do is tell them, okay, only keep 2 of these acceptances, make sure to free up the other acceptances so that the medical school then would be forced with having to make the decision to accept more black, because they want to put a certain number, say 5 or 10 black medical students in their class, and they don't go beyond that. Okay, so if they don't have the chance to choose, if somebody hold on to all their acceptances until too late, somebody basically doesn't get into medical school. Now, one of the other things that happened, I learned that back in the 1970s very quickly. I met with my dean of students, who was really very friendly towards me, and I asked, why is it that my class has so few black medical students? There were 3 of us who went and met with her. And she said, well, you're looking at the best people that we could get here. We try to find people, we cannot find them. But, come on. Everybody cannot keep on giving the same answer. That pipeline issue has been debunked, but deans and professors at medical school keep on saying the same thing. So if we have black medical schools at HBCUs, then that won't be an issue anymore. This pipeline issue would have disappeared.
Thank you, Dr. Cadet. We have a couple more questions. Someone asks, is it correct that the type of drugs correlate to socioeconomic status and accessibility? Do opiate drugs depict this correlation? Hence, is it showing up in death higher for Caucasians? I think you hit on this a little earlier.
So I think the biggest thing that happened as far as the war on drug is concerned was the criminalization of marijuana use and the disproportionate treatment for crack cocaine and cocaine. Now, with what ended up happening is that most of the people, young black people, depending on how much drug they had on, ended up in prison for a long time. Now, the decriminalization movement started to happen, I would say luckily, for black men and women when the opioid really overdosages, the increased prevalence in white Americans occurred a few years ago. So that started people thinking, wow, we need treatment for people, okay? And a lot of people complain that, wait a minute, why is it that we need treatment for opiate use disorder, but prison for cocaine use disorder or marijuana use disorder? So I think now there's a movement, and I'm very happy to see it, to try to decriminalize all of the drugs. But I don't think the drugs are related to social class necessarily, because I think they are both environmental and genetic and epigenetic basis for who becomes addicted to drugs or not. I mean, we've done some basic science studies where we take a bunch of rats that came from simulators and put them through drug self-administration. And they're all from the same environment. So they learn to take the drug. But then if we apply adverse consequences, okay, then but in the case of methamphetamine, 50% of them will stop taking the drug, but there's another 50% that will continue to take the drug, even though they basically came from the same vendors. Everything is the same in our experimental area. So I think we need to look at those more so than just social class. But the stress of racism, though, might impact the amount of drug that somebody takes, whether it's opioid or cocaine or methamphetamine or marijuana. I think that's true, but it's not just social class. There are some other determinants like genetics, epigenetics determinant.
Thank you for that. We have one more question. Dr. Cadet, who do you feel is best to donate time and money to? Are there local groups or national groups that you would recommend?
So, because I'm in Baltimore, I give almost all of my money to the Thurgood Marshall College Fund. I mean, I love Thurgood Marshall. As you can see, I put his name in the middle of my talk. I think he's not as big as, say, United Negro College Fund, but I think if either of those two are really good organizations to give money to. Because the thing is, we need kids from poor economic background to be able to go through school with not too much debt. I think in terms of the schools that I talk about, the HBCU and the medical school, one of the prohibitive factors sometimes with kids who are really smart, but when they look at the cost of medical school, they choose something else. And then sometimes I have to try to convince them, oh, you're going to be able to pay the loans. I was able to pay my loan. So you're going to be able to pay the loans over time, but we need Black physicians. And I've been able to convince some to continue, but others say, no, Dr. Carter, I'm not going to do it.
Well, thank you. It looks like, I don't know if there are any other questions. Whoops, I have some echo, I apologize. If there are any other questions that anybody has, please submit now. It looks like people do want to, if you are able to share your PowerPoint slide, people would love that. If not, just let us know.
No, you can, I mean, I think everybody needs to know about this. And usually, if you send me the tape version, I share them at work, and I share them in some internet that I participated. But you feel free to share this.
Wonderful. Thank you. We will definitely share the participants. This is an incredibly important topic. We're very fortunate to have you. Looks like we've got a lot of thank yous for this, a lot of people commenting it's powerful, heartbreaking. A lot of people weren't aware of some of the historical abuses that occurred in medicine and science. So we're very grateful that you were here to share this with us today.
Thank you very much. I'm very pleased to be here with you today, and I'm very, very glad to see that everybody recognizes that racism is really blocking our path to a better union. It's not having the different ethnic group that's blocking the growth. Having different ethnic group is great for a lot of reasons, social reasons, food. I'm a foodie. I love going to other houses where food that I can enjoy and other colleagues that I can work with. But racism as really is a very bad factor for the country to meet, uh, it's, to be a perfect union. So having an
Absolutely.
opportunity to talk about that is great for me. Thank you very much.
Thank you so much, Dr. Cadet, and thank everybody for attending, and we will make sure to get you your CEU and copy the presentation. Thank you, everybody. Thank you, Dr. Cadet. Thank you. Have a good weekend, everyone. Thank you.
Bye.